recorded. If you require any further assistance, please press star zero. I would now like to hand the conference over to your speaker today, Mr. Michael Schomer. Thank you. Please go ahead, sir.
Thank you for joining us for the COVID-19 media call for July 15th. We'll start today with a situation report from Health Commissioner Jan Malcolm. We'll also hear some opening comments from Infectious Disease Director Chris Erzman and State Epidemiologist Dr. Ruth Linfield. After those updates, we'll open it up for questions on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. I'm going to be quite brief today with just some of the basic data. Around the world, as of this morning, we were above 13.3 million cases and 578,000 deaths from COVID-19 disease. In the United States, we are now above 3.4 million cases and 136,000 deaths. Just to put this in a little bit of context, what this means is that the United States, which has about 4.5% of the world's population, accounts for fully 25% of the global COVID-19 cases and 23% of all deaths. Here in Minnesota, we're announcing today an additional 578 laboratory-confirmed cases from yesterday, bringing our new total to 43,742 cases. The median age of our cases continues to trend down. As of yesterday, it was 37.5 years. It was down from 38.2 just a week ago and 40.5 a month ago. We had, unfortunately, 8 additional Minnesotans who died of COVID-19 disease yesterday in Minnesota, bringing our new total to 1,518 of our fellow Minnesotans, our families, our friends, our neighbors. 2 of these individuals were in Hennepin County, 1 each in Anoka, Dakota, Grant, Nicollet, Pipestone, and Ramsey counties. This was 1 person in their hundreds, 1 in their 90s, 1 in their 80s, 1 in their 70s, 2 in their 60s, 1 in their 50s, and 1 person in their 40s. There are currently 254 patients currently hospitalized, and an increase of 18 over the day prior, but actually 1 fewer in intensive care at 106. With that, I just want to remind us again of the relationship between the tests, the total testing volume, and the positive cases. Yesterday's increase of 578 cases was on an increased testing volume of 12,473 yesterday. So that's kind of the rebound that we expect to see after some of the changes in testing patterns that happen certainly over the 4th of July, but also typically happen on the weekend. The 7-day average testing positivity rate is 4.8%, which is an increase from 4.7% the day prior and up from 4.4% a week ago, 3.8% 2 weeks ago. So you can see with the testing positivity rate, the definite trend upward there, not at a super accelerating rate, but still a steady progression up in terms of our test positivity rate. Week to week, we saw a 13.6% increase in total tests done and a 10.5% increase in new cases since last week. So that is, again, one of the larger percentage increases week over week in cases that we've seen since the late spring. With that, I'm going to hand it over to Chris Erzman for some comments. Chris.
Thank you, Commissioner. I want to talk about Make a Plan Minnesota. As Minnesota works through the COVID-19 public health crisis, we know that more people will become sick and require hospitalization. And we also know that when one person in a household gets sick, the other people in that household are at higher risk of illness as well. As we see cases rise again in Minnesota, we want to remind everyone that it's a good idea to develop plans for how you would deal with an emergency that might prevent you from caring for your young children. There have been instances around the country and here in Minnesota where parents have become too ill with COVID-19 to care for their children for short periods of time. Make a Plan Minnesota is a new campaign developed to urge parents and guardians to develop plans for alternate short-term care for their children in the event that they become seriously ill. By compiling critical information like your child's medical or educational needs, as well as other important information like their preferred routines and comfort times, you can ensure that any needed transition would be easier for you, for the person caring for your children, and for your children. We have developed a tool collaboratively with families, counties, and tribes to help families with this planning. For more information, go to mn.gov/COVID-19 and find Make a Plan Minnesota. This information is helpful now, but it's helpful for any time in your life to be prepared. The next thing that I wanted to comment on is just the fact that Minnesota was placed on the New York, New Jersey, Connecticut quarantine list. In our last few media calls, we've been sharing our growing concerns about the uptick in cases of COVID-19 in Minnesota. You'll recall that we reported nearly 1,500 new cases just over this weekend. Yesterday, we saw a reminder that other states are noticing our case increases as well when New York, New Jersey, and Connecticut imposed a 14-day quarantine on anyone arriving in those states from Minnesota. Minnesota joined Wisconsin and 20 other states that are now subject to this quarantine measure in New York, New Jersey, and Connecticut. According to the state's public health officers, the list is comprised of states with a 7-day rolling average of either COVID-19 test positivity rates greater than 10% or daily new cases per 100,000 of over 10. As we mentioned yesterday, the 3 states use data from the CDC COVID tracker to evaluate which states to include in the list. The tracker reflects the data a COVID case is reported. The tracker reflects the date a COVID case is reported, not the date the specimen is collected. In Minnesota, we report COVID cases by specimen collection date, which means our data was reported online will differ slightly from the data source used by New York, New Jersey, and Connecticut. Our data will show the same number of cases, but associate them with slightly different dates. Due to this difference in data presentation, upon hearing the news of Minnesota being placed on this list, we needed to look into their numbers to verify the accuracy of their information. The bottom line, of course, is that we are seeing an increase in COVID-19 cases, and we must do our part to slow the spread if we want to avoid additional cases and their implications. And with that, I'll turn it over to Dr. Linfield.
Thank you, Director Erisman. I wanted to just make a few comments. Just some comments in general on the pandemic and a reminder that all of us have a role to play. People are tired of hearing this, and we know, but even if we feel like we are done with this virus, the virus is still here. And in fact, if you look at other states and some of the indicators that Chris described, you can see that we are still experiencing the pandemic, and we are in fact at a worrisome point in that the numbers are going up. From a national perspective, there are now 41 states that are having an increase in cases. This really is a moment for all of us to take a step back and think what we can do to slow transmission and to slow the course of this virus. Where we go from here as a state is less about what the small number of public health workers and healthcare providers can do. It's about what each of us as Minnesotans decides to do every day. Doctors, nurses, public health workers, small business owners, community leaders, long-term care providers, teachers, school administrators, and service workers around the state are all working very hard to protect Minnesotans and to make it possible for some of us to have some level of services and recreation this summer. But as much as they are all doing, it is not going to be enough if all of us don't do our part every single day to help reduce the spread of this virus. We may not be in the worst shape currently when you look around the country, but we are not in the best shape either. As you can see, we are now on the quarantine list. There are, in fact, other states, and there are other countries that are doing better than us. And that should be really an inspiration for us to really try to work harder, because as Minnesotans, we care about each other and we care about public health. Every single Minnesotan has the power to help reduce the spread of COVID-19 and protect themselves, their families, and their communities. We have the power to protect our small businesses and our local economies and make it more likely that we will be able to get back to activities and to services that we all are craving for. We each make choices every day whether or not we are going to use precautions and how much we're going to use precautions. And when we make these choices, we need to be mindful that our choices do not only affect us, they affect the health of our families and of our communities. It isn't a discussion about blaming or doing things wrong, but what we want to communicate is each of us have a responsibility and have the ability to work hard about preventing transmission of this virus. We know that there's a lot of conflicting information out there. We know that people are sick and tired of precautions and hearing about precautions, but this is not the time for us to let up our guard. The virus is out there, and we do want to have some control. We want to be able to live in a pandemic as best as we can, and we want to be able to, in the fall, be able to continue to do things such as school and other activities that are important. Every few days, it seems we see new and hopeful headlines about vaccine development. And good news on that front is welcome. However, we should remember that it will be a long time, in the best scenario, many months, from having an effective vaccine that is available for us. Until that time, it is really up to us to make the choices to limit the spread. And this includes practicing social distancing, washing your hands, wearing masks when going out in public, getting tested when you develop symptoms or have an exposure, self-isolating between the time when you are tested and you get the results, and of course, staying home when you are sick. I would like to turn it back to Mike Schumer.
Thank you, Dr. Linfield. Operator, we're ready to take questions now.
As a reminder, to ask a question, you will need to press *1 on your telephone. To withdraw your question, press the # key. Please stand by while we compile the Q&A roster. Your first question comes from the line of Jeremy Olson from Star Tribune. Your line is
Hi,
open.
thank you. Thank you. Dr. Linfield, I wanted to ask this today. Fairview, mHealth Fairview is announcing a retail antibody testing option. People don't need a doctor's order. They can just call up and get antibody testing to see if they have had COVID-19. Given what you just talked about, I wondered what you thought about that, and given the limitations we know about antibody testing. Is this a good thing or a bad thing in terms of helping with some of the goals you just mentioned?
Yeah, thanks for the question, Jeremy. As you know, and as we've discussed on these calls, there are still questions about immunity and about the length of immunity. And we don't yet know what constitutes protective immunity and for how long it may last. And so the other point I did want to make, and we also have discussed on this call, is that there are concerns about the positive predictive value when the prevalence is low. And we still feel that the overall prevalence in Minnesota is low. So I have a couple of concerns about antibodies. They're still the same concern, which is on an individual level, there's a possibility that there could be false positives and false negatives, and that we don't know how long the protective immunity lasts. And so although CDC, FDA, and researchers are continuing to look at this issue, and I do hope we will have more clarity in the future about it, it is hard to interpret for a particular clinical situation an individual result, with the exceptions of has been helpful for us in these children who have the multi-system inflammatory syndrome that appears to be associated with COVID. A number of them have been PCR negative, but antibody positive, and this is a syndrome that does appear to be associated with SARS-CoV-2, but seems to occur a number of weeks after an acute infection. The other area also is for convalescent sera, convalescent plasma, and this is something that is being used to treat patients and certainly individuals who have had COVID who would want to donate their plasma. That is something we would absolutely encourage, and that is being used in the clinical situation, and people can contact the Memorial Blood Center or the Mayo Clinic to sort out that situation. So I hope that's helpful for you, Jeremy. We do continue to be interested in looking at the seroprevalence of Minnesotans to get a sense of how many people have been exposed to the virus. We did share some results a week or two ago about blood bank donors, and we are planning on doing some more studies. And as we get those studies in place and get results, we will, of course, share those results with you.
A follow-up question.
Oh, we lost you, Jeremy.
Your next question comes from the line of Chris Magan from Pioneer Press. Your line is open.
Hi, thanks for taking my question. I was hoping you could talk a little bit more about what we're learning from the treatment of the serious cases and the deaths. The death rate is down, and I know that in the past you've said that the deaths do lag the new cases that we're seeing. But I'm wondering if you could talk a little bit more about whether there's other factors at play there, if we're getting better at treating serious cases of coronavirus in the hospital and ICU, or if there's other factors in play at the lower death rate, or if it's just a delay because of the lag time. Thanks.
This is Commissioner Malcolm. I'll just remind you, and I know perhaps not all the reporters were on the phone when we had both Dr. Hick and Dr. Linfield on, I think 10 days or so ago. Dr. Hick talked at that time about the fact that indeed there have been some advancements in approaches to treatment as physicians have learned more about caring for COVID, and that is impacting the treatment approach, and has he said has some impact on the lesser use of ICU capacity as oxygen support is being given earlier in the course. But I will turn this over to Dr. Linfield for a further comment.
Yes, thank you very much, Commissioner. So as you allude, there are a number of factors involved. Certainly, as the Commissioner has discussed, we do have some treatments that are being used now that do appear to improve the course of illness. Another thing to keep in mind is that for a period of time, we were having outbreaks in long-term care, and of course, that population is very frail and fragile and at high risk for severe disease and death. And long-term care has worked very, very hard to improve their ability to detect infections and to prevent transmission, and we are seeing major improvements in that area. And so the number of outbreaks in long-term care facilities has gone down. And then, as you point out, deaths are a lagging indicator. One thing we are noticing now, as the commissioners point out, is that the median age for cases has dropped, and we are seeing more cases in young people. And even though those young people in general may not get severe disease, and we know some of them do get severe disease, but in general they're less likely to get severe disease, they may spread it to family members, to coworkers, to other contacts who have underlying conditions or who are older and do get severe disease. They may be working in long-term care or in another setting where they are exposed to older individuals. And so we are now starting to see an increase in hospitalization, as the commissioner pointed out. And if Minnesota is similar to other states, they are now starting to see an increase in deaths. And I am sad to say, but I do expect to see an increase in deaths in the coming weeks.
Your next question comes from the line of Catherine Richard from Minnesota Public Radio. Your line is open.
Thanks. So we've been hearing for the last few weeks that a lot of these clusters among younger people are happening in places like bars, but then also in private settings, like I think you mentioned cabin weekends, that sort of thing. I know you can't do much to control that, but is there any discussion around closing bars again? Have you guys recommended that to the governors?
This is Commissioner Malcolm. We are very much keeping track of the data on what we know about the hotspots that are emerging. I'll just say this is pretty much of a continuing day-to-day conversation about where are we seeing hotspots, where are we seeing clusters, what can we do to mitigate that spread. Don't have anything to announce today, but I just can restate that we're working very closely with leaders from the hospitality sector and really stressing the importance of compliance with the guidance that we have out there about restricted capacity, no standing around in bars, the social distancing requirements and the like. And we are stepping up enforcement in those areas. So it's been our focus to make sure that the guidance is known and understood and followed by everyone. But we do continue to track the data and are also watching with interest what other states are doing and whether they can point to any impact of those actions on their transmission rates. So we're actively reviewing it.
And to that end, Dr. Linfield, too, just mentioned that she expects to see deaths increase in the coming weeks. How are PPE levels? Do you think there's enough for the surge, especially as hospitals have started to resume elective surgeries?
Yes, thanks. We do track PPE levels quite closely. The hospitals report what they have on hand, as well as what we have kind of at the state level. As you know, we have not been in the business at the state level of stockpiling PPE or equipment. That's traditionally been something that the federal strategic national stockpile has done. But with that not being an available tool to us, we've sort of filled that gap with a lot of state procurement, and we do have quite a bit of supply on hand currently. And I think the specific metrics about how many days on hand we have can be seen on the COVID-19 webpage. But I will say, just as we've mentioned in recent days about supply chain issues reemerging in terms of laboratory supplies, whether that's reagents or other things associated with the collection of supplies and the processing of them, the same is actually beginning to reemerge with PPE as well. So we are, let's just say we're not assuming that we have enough. We do have a very good supply right now, but because of what we're seeing with the global supply chain issues reemerging, we're continuing to look to source additional supplies of some of the high quality, masks and gowns and the like that we anticipate needing as this pandemic evolves, and as we've talked about, the potential for kind of co-occurrence in the flu season.
Okay, thank you.
Your next question comes from the line of Paul Scott from Foreign News Service. Your line is open.
Thank you. Hi, I'm wondering if you can clarify whether Minnesota is going to be affected by the decision of the White House to effectively cut the CDC out of the reporting, directing COVID information to a new centralized system. Do hospitals in Minnesota report first to you and then to the federal government, or how does that work?
Yeah, this is Commissioner Malcolm again. Yes, we are affected by it. We're concerned about it. This guidance was just given, or this directive was just given yesterday to be effective today, to make sweeping changes in what data are reported and how, and that's obviously a significant logistical challenge. And the fact that the CDC finds great value in being able to look at this data to inform their tracking and their advice to us is a deep concern to us as well. But yes, here in Minnesota, we have been through the State Emergency Operating Center, compiling that data from the hospitals and submitting it on behalf of all the hospitals in Minnesota to the federal government via the prior data platform. Now we're being told we need to switch to a new data platform. Have no insight into why that is necessary, what was not working with the old platform. That explanation has not been offered to us, but we are in the process of doing the work to figure out how to comply with the new platform, as the federal government has said that they will only respond to requests for PPE and remdesivir if we're using the new platform that they're prescribing. So it's urgent that we figure out how to do this if the federal government can't be persuaded to not make this change. That is not anything we're in a position to do, obviously. So we're doing the work of figuring out how to convert the data submission, and it's a lot of work, but yes, we are doing that on behalf of the hospitals.
So to follow up, it's not going to affect what you know about the incidents in Minnesota, but what do you anticipate how it affects what you know nationally?
I would ask Chris or Ruth if in conversations with their colleagues at the CDC, if they have any specific things they'd point to. Just in general, it's just any delay or extra hoops in the sharing of data is not welcome at this point in time. But Ruth or Chris, do you have anything to add?
Yeah, Oh, go ahead, Chris. It's fine.
No, you go ahead. You go ahead.
Okay. Just some clarifications. The data that we will be reporting to HHS is on the number of hospitalizations, the number of beds occupied by those individuals who are SARS-CoV-2 positive, the remaining number of available beds. These are both general hospital beds as well as ICU. We will be reporting on how much PPE we have, as well as whether we are using the remdesivir that has been allocated to the state, and how much is left over. Regarding individual case reports, that we will continue to report to CDC. We still fully intend to work very closely with CDC in our response to this pandemic. And CDC will also have access to these data from states that are being sent to HHS. So it is cumbersome. It's a new way to report. We had used another system, the National Healthcare Safety Network system. That system is still going to be used for long-term care reporting. So there will be some additional systems in place, but we do fully intend to retain working closely with CDC.
Thank you.
Your next question comes from the line of Sue Kraft from Mahoman Pioneer. Your line is open.
Thank you. See, our rural school districts up here have been working diligently on preparing their 3 plans for education this fall. And, whether they're going to be there in person or they're going to be remote, or whether they're going to be a hybrid form of that. And each one of those plans involves a different set of expenses and preparations that have to be made. And so it's becoming very crucial to know when it's going to be decided which plan they're going to start school under, who is going to decide that, and if there are going to be regional differences involved, whether things are going to be different between up here in the Northwest versus down in the metro area by the cities. Can you please answer those questions? Thank you.
Hi, this is Commissioner Malcolm. And as we've mentioned on prior calls, this is a decision that the governor and the Department of Education will be making. And we at the Health Department have been working very closely with our colleagues at the Department of Education on the guidance around this from a health perspective. As I've mentioned before, and I think the governor has too, the fact that schools and districts have been encouraged to develop all 3 plans, and you're completely right, they all have different assumptions with them, but the reason that's so important is we think it's very possible that the state and individual areas may be using some combination of all 3 plans during the year. So I think the intent is for the Department of Education and the governor to announce, and they had said previously that would be announced by I think the week of July 27th. The governor has said he'd like to accelerate that if possible, but partly because of what's the recent changes in the disease profile around the country and in Minnesota, we want to make sure we're fully examining all relevant data. But we've been working on this. That announcement will be forthcoming no later than the week of July 27th in terms of what sort of the starting point, if you will, or the default assumption. But just to clarify, all 3 of those scenarios are going to remain important for as tools and for planning purposes. And in terms of how that will work in terms of local decisions versus statewide decisions, I'd need to refer you to the Department of Education for that.
Thank you.
Operator, we have time for one more question.
Your next question comes from the line of Chris Harowski from Care 11. Your line is open.
Okay, thank you very much. I greatly appreciate you taking the question. So, you know, when this political debate hits social media or the airwaves, however you want, people who don't want to take it as seriously as others say that we're not reporting on the mortality rate. And I just want to see if there's a way you can clarify what the current mortality rate of SARS-CoV-2 is, and if that's even the right question. If it's the right question, might be what is the mortality rate for different ages and populations? Thank you.
Yeah, we definitely do report the mortality statistics every day and on our website, and we do break that down by age demographics. And certainly we think that is a critical indicator, but it's not the only indicator. This disease can be devastating. It can have very long-term health consequences that we're just beginning to understand. So certainly we think the mortality figures are critical, of course, but not the only indicator that should suggest how seriously we take this or how aggressively we try to mitigate the harms of this disease in our communities. But Chris, maybe you could just comment further on the current breakdown by age ranges, or however you'd like to address the question.
Sure. I absolutely want to second what the commissioner said, that any one indicator is extremely valuable, but a single indicator is not sufficient to really understand the breadth of this outbreak. And obviously, fatality is the worst outcome that an individual could have. But as the commissioner said, we're learning that even people who may have had asymptomatic infections can have long-term health consequences and sequelae. So I just want to reinforce that. Looking at our numbers, we have not had any deaths in individuals from birth to age 19, so no case fatality rate there. But in individuals in their 20s, so from 20 to 29, the case fatality rate is 0.02%. We've had 2 deaths out of a total of 10,097 cases. In the 30 to 39-year-old age group, the case fatality rate is 0.13%. That is 11 deaths out of 8,256 cases. In the 40 to 49-year-old age group, the case fatality rate is 0.31%. That is 20 deaths out of 6,441 cases. In the 50 to 59-year-old age group, the case fatality rate is 1.36%, 78 deaths out of 5,741 cases. In the 60 to 69 group, the case fatality rate is 5.47%. That is 184 deaths out of 3,366 cases. In the 70 to 79 age group, the case fatality rate jumps to 15.26%. That is 287 deaths for 1,881 cases. In the 80 to 89 age group, the case fatality rate is 30.82%. That is 516 deaths out of 1,674 cases. In the 90 to 99-year-old age group, the case fatality rate is 44.48%. That's 391 deaths out of 879 cases. And in the 100-plus age group, the case fatality rate is 58%, 29 deaths out of 50 cases. We're fortunate that Minnesotans are long-lived, but you can see that the case fatality rate increases with age. But as we've talked about, there are consequences for individuals who are younger, in younger age groups in terms of long-term sequelae, and cases in those age groups can impact spread in the greater community and ultimately impact our most vulnerable populations. Thanks.
Thank you. Thank you very much for that. That helps a ton. I really, really appreciate those stats.
That is all the time we have for the call today. If you did have a question we were not able to address, please feel free to reach out to MDH Communications this afternoon. Have a good day, and we'll be back with you again on Friday.
Ladies and gentlemen, this concludes
This has been a WDIO News Special Report.